Welcome everyone to today's webinar, Creating a Data-Driven Network Between Payers and Providers, sponsored by Exelis. I am Brian Zimmerman from Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It's now my pleasure to introduce today's presenters. Joan Butters is the Chief Executive Officer at Exelis. Prior to founding Exelis, Joan served as Vice President and General Manager of Strategy and Emerging Solutions at Optum, where she identified and developed new technology solutions and provided services across the healthcare ecosystem. Joan got her start in healthcare at AIM Healthcare as Vice President, Data Mining Technologies, serving as a key member of the senior leadership team responsible for the formation and growth of AIM Healthcare prior to its acquisition. George Renadin is the Senior Vice President, Retail East and Provider Experience at Humana. He oversees market business operations, market clinical operations, product development, actuarial, Medicare finance, Medicare risk adjustment, and network and sales strategy for over 2.3 million Medicare members. In addition, George leads Humana's nationwide provider organization, inclusive of Humana Alliance Partners, value-based solutions, and provider contracting. Doug Gertner is the Chief Executive Officer at IVX Health. Doug brings over 20 years of healthcare experience to IVX Health. Prior to IVX, Doug served as CEO of Change Healthcare prior to its sale to MDON in 2014. Doug is a member of various corporate boards, including Exelis. And at this time, I'm pleased to turn the floor over to Joan to begin today's presentation.
Great, thank you, Brian. Appreciate the introduction, and thank you to my co-panelists, George and Doug. Needless to say, both have a proven track record of innovation, leading organizations to new paradigms of delivering patient-centered care, and certainly seeking better ways to manage healthcare operations. So thank you both for joining me today. I am excited to be to facilitate our discussion today. As Brian mentioned, I've been in healthcare for almost 25 years and have built solutions that have influenced healthcare operations, but I've never been more excited about the work we're doing today, not just to influence, but to change the paradigm of how payers and providers collaborate. A couple of meaningful topics that we're going to cover today. What burdens the current ways in which providers and payers collaborate, and more importantly, why must that change? How relationships and collaboration between Humana and hospitals and health systems across the nation are changing by using Cortex and our AI shared framework for and how AI and data-driven technology set the stage for better payer-provider engagements and partnerships. So a lot of conversation of late about the need for payer and provider collaboration and expanded partnerships. Before we dive into what Humana and Exelis are doing together in that area, Doug, would you mind sharing your thoughts on some of the challenges in improving collaboration through data? And I think more importantly, what are some of the broader opportunities when we do?
Yeah, absolutely. So thank you for having me today. I mean, I think when we look at that relationship between payers and providers, there's a lot that's going on today that maybe hasn't necessarily existed in the past. And, I would tell you three primary areas come to mind for me. So one, you have a massive shift from a site of care perspective, right? Whereas the hospital was sort of the center of the care universe previously, you are seeing a migration outside the four walls of the hospital. Whether that's to ambulatory surgery centers, whether that's using telemedicine, whether that's urgent care, it's outpatient imaging, frankly, it's infusion centers. You're seeing a meaningful shift, and I think that in and of itself drives different behaviors, both as a provider organization, but also as a payer organization as well. I would say the second thing that you see really is around the data side of things. And I think that's an important one because data is really the foundation of how decisions get made. And when we look at data, there are three things going on between payers and providers that I think are really important and that inform how people are making decisions. First and foremost, what you have is this inherent asymmetry of information. What a payer knows about a member is oftentimes very different than what a provider knows about a patient. Both organizations are trying to make the best decisions that they can with the data that they have, but they have different data sets. And so I think that's one thing that really does factor into how payers and providers are working together. I'd say the second is around standardization. So a big part of what we're seeing is there are increasing trends towards standardizing that data so that as it goes back and forth between payer and provider, it's in a language and it's in a format that both of those organizations can consume it and act upon it, right? And whether that's the FHIR standard, whether that's some of our traditional EDI transactions that exist, I think that's definitely playing a role. And then the third thing I would say is just latency. At the end of the day, decisions are being made based on the data that folks have available in the moment. And this issue of latency is a very real one because even if both payers and providers have the same information, oftentimes one of them has it sooner than the other. And so, I think this data inefficiency, I guess, if you will, creates an opportunity for us as we go forward. And I think that's one of the biggest gaps that exists today. I'd say the third thing that's probably driving some inefficiency is pertains to the motivations that are driven just by the reimbursement structures that are out there, right? Everyone is talking about this move towards value-based care. What's interesting, though, is that when you look at it, 90+% of providers and payers would tell you that they have a contract that is value-based or risk-based in one way, shape, or form. But when you dig into that and you actually look at the dollars at play, probably less than 25%. In fact, I just saw a study last week where only 4% of dollars are in a true upside or downside risk scenario. And so we're seeing a shift towards value-based care. I don't know if we'll necessarily see a shift in true behavior until more dollars are at play and not just sort of the contracts that exist out there. The only other thing I would add that does sort of overlay all of this and creates inefficiency, albeit well-intentioned, is from a regulatory perspective. We still have very real issues on the antitrust front around how payers and providers can collaborate, how providers can collaborate even amongst themselves. And so that's the one other piece that sort of sits there that is probably worthy of consideration. Joan, I'll pause there and happy to go wherever you'd like from here.
No, Doug, those are great comments, and I guess I'll throw it back to George. Any comments you care to share on Doug's comments, specifically and timely? An article was published just today by Humana CEO Bruce Broussard that talks about the need for payers and providers to adopt a omni-channel approach to meeting patient needs, kind of that talks about sites of care given the different dynamics and the change of sites of care. Certainly, I know that you have some practical examples of communication and data, and then Humana's own efforts around value-based care. But would you mind kind of commenting on Doug's comments and then these three specific areas of opportunity?
Sure, Joan. So, I think Doug really hit it pretty well. I'd like to talk a little about the data piece of it. What we're finding is that the two specific things that Doug talked about with regard to asymmetry and latency are absolutely the reason for a lot of the inefficiencies and the questions that go back and forth between us and the provider. It's incredible to me today how we don't have the type of technology that allows us to connect better. Because many of the discussions, many of the disagreements that come up between providers and payers has to do with both the asymmetry and the latency. One of the things that we're definitely working towards, and I think Cortex from Exolus is one of the items that will help us there, is so that we're getting real-time information. So I think that is something that can be worked on, and we need new solutions to it. There's no way we'll ever fix those as long as, frankly, we're still using fax machines. I can't even believe that comes out of my mouth that we're still using fax machines, but we are, and that's just, frankly, just needs to stop. So I think that the data points that Doug brings up are absolutely on point. With regard to the site of care shifts, look, we're seeing it. Everyone's seeing it. We had very, very, very little use, for example, of telehealth going into COVID, and now we're seeing very rapid use. You know, it was not even a fraction of a percent of the interactions for our members and our claims before COVID. But what we're seeing even with our better performing providers, our extremely engaged value-based providers that are doing a good job with their members, you know, we're now seeing about a 40-40-20 split. When I talk about 40-40-20 split, what I'm saying is about 40% in person, about 40% has some form of video connection, and about 20% is telephone only. And we're seeing that across our specific, those practices who focus on seniors even. And so there's been some discussion about, will seniors take up? The answer is yes. There's also been some question about, you know, what about the ability technology-wise? We're not finding that to be a huge issue. So the split and shift in site of care is absolutely here, and I think it's probably here to stay. I don't know if it'll stay in the current ratios that we're seeing, but it's definitely something that our better performing value-based providers are seeing, and they're trying to see if they can keep it that way in order to decrease infection risks, et cetera. So that shift's absolutely happened. With regard to value-based, it's interesting. I think that really changes as we continue to move forward. We are, as a company, seeing, you know, with our value-based providers, we have about 2/3, 67% actually, of our membership in our Medicare plans are assigned to a provider who has a true value-based contract, meaning upside or downside. And what we're trying to do is we are, as Doug talked about, trying to change that ecosystem so that more of the healthcare system is involved in value-based. You know, we now have programs that include, of course, the PCPs that we always have, but we have a number of specialty bundles. We just announced shoulder and cabbages, for example, are adding to the list. So we have specialty bundles are out there. We have hospital incentive value-based programs. We've had for quite a few years now pharmacy value-based arrangements with both the pharmacies and with pharma. We have home health value-based arrangements that we're working on. And going into 2021, when Medicare individuals with ESRD can enroll directly in the Medicare Advantage plan, we now have value-based arrangements and contracts, real, as Doug called them, real value-based, with various CKD and ESRD dialysis providers. So we're trying to expand the scope of that because I do think, as Doug mentioned, that motivation or reimbursement is changing the way people look at a lot of these historical issues between providers and payers. I think it's the only way we're going to get our incentives aligned, and all those need to happen, to circle back to my first comment, on the rails of a better data foundation that allows for better real-time communications between providers and payers so that we're all driving towards the same thing, which is better health outcomes for the members and for the providers' patients.
Yeah, thank you for that, George and Doug. Certainly appreciate those comments relative to the broad areas of opportunities, and then more importantly, how data and access to data and is the cornerstone of improved collaboration and changing, to George, to your point, the paradigm in which payers and providers collaborate. One of the things that I think is of interest, or we've talked about in prior conversations, is this concept of how the movement of healthcare reimbursement needs to go from volume-based to value-based, from the per-click healthcare system towards a new way. And I think a lot of the things that Humana is doing and other payers are doing relative to value-based care, Doug, your mention of the movement and the need to embrace value-based care really does get us to a different way of reimbursement, does get us to a different way of collaborating for sure. But again, the cornerstone in my mind is the access to and sharing of data. Did I get that right in terms of how how data plays a role in really shifting the paradigm or a different ecosystem relative to reimbursement strategies and and more importantly, better payer and provider collaboration.
I think certainly from my perspective, I was going to say, Joan, this is Doug. I mean, from my perspective, I think you certainly did get it right, because I think with greater or with better data, I think people are more comfortable taking on risk, right? Because it's informed risk taking. And, I think the more current that data is, the more comprehensive that data is, the more complete that data is, I think the more comfortable people will be in taking on risk and getting away from that traditional sort of per-click system in which we operate today.
If I can just use an example, a very specific example of how better and more current data makes a difference. We have various reports that we use to help our value-based providers do a good job, and we had a very large group in Baton Rouge, Louisiana that we interact with, and they were seeing that they were having some issues with their historical performance had gotten worse. And one of the things we did is we were able to, through data, drill down and figure out that, and through the reports we provide them, figure out that, for example, they had hired a couple of new physicians who were not seeing their patients on as regular basis as the physicians who they've had in their practice for a long time. And what we are seeing as a result of that is more of those physicians' members were going to the emergency room. When they were going to the emergency room, were being admitted. And it all came back to the fact that these newer physicians weren't practicing the way this clinic and the rest of their physician community did. And it was by being able to see that data and information that we could focus in and say, it's these doctors and these patients that aren't being seen. And once that was known, it was almost like a light switch. It almost immediately changed, because then they put in place proactive solutions to engage those patients, bring them into the clinic, and get them seen and maintain their health and even improve their health, whereas before there was a larger proportion of those who were going to the emergency room and being admitted to the hospital. That was a failure of the healthcare system. Those ER visits and those admissions are a failure. And I think that the change to value from volume helps us get there, where we decrease the gaps in care, which leads to better health outcomes, which is the motivation for all of us in this healthcare system. But it couldn't have happened if we didn't have the data. And if the data lagged a long time, frankly, we'd have an issue, because we wouldn't be able to have caught that these patients weren't being seen. So I think that this example just really puts in context of what it means to the patient and what it means to the system to have data and value driving the outcomes.
Absolutely, George, and thanks for those comments. I think, we've been talking, all these are very, relevant topics. We've been talking a lot about collaboration, data sharing, a little bit of how artificial intelligence plays into the ability to better understand what's right for the patient, better understand how to collaborate. I now want to turn our attention to the practical application of data sharing in healthcare, and in particular, the application of that in the utilization review space. So just a little bit about Exelis. So we were founded in 2013 with the promise of addressing the operational challenges of managing UR. Again, a very practical application of data sharing, collaboration, and artificial intelligence with a real-world application in healthcare. Some of those challenges that we saw very early on in utilization review were subjectivity in decision-making. We talked about this, or at least made inferences to it, the friction in the process that exists between the payers and providers, reliance on people, technology, we're making strides there, not far enough along, and then certainly the waste in the system related to the repetitive and duplicative efforts by both payers and providers. So we thought, when I founded Exelis, co-founded Exelis, the application of data, artificial intelligence, data sharing really helped us to formulate and focus on a data-driven network between payers and providers to do this process, to manage the utilization review process just a little differently. Cortex is our SaaS solution that interfaces directly real-time with hospitals' EMRs. It processes and standardizes that data that we talked about, that asymmetrical, unstandard, and latent data. Again, we're talking about real-time data. We're talking about the standardization of data. We're talking about the comprehensive and longitudinal nature of data. So that all runs through our Cortex, our SaaS solution, and creates a comprehensive clinical picture of a patient or member's condition. Again, we can't emphasize enough that application of data in a way that's consumable to the end user. And then even more importantly is the application of artificial intelligence and machine learning. In our process, we score each patient through artificial intelligence and machine learning to determine the appropriate level of care while the patient's in the hospital, real time while the patient's in the hospital. And then the underlying analytics, real-time analytics, consolidated picture of the clinical picture of the patient becomes the common framework from which payers and providers facilitate timely, seamless, cohesive, and data-driven level of care decisions. So really is changing the paradigm and shifting away from all, the challenges that we noticed, that we identified early on in our journey in terms of subjectivity, in terms of duplicative work, in terms of friction, and the lack of technology. So very excited to be in the space providing these types of solutions to the payer and hospitals, healthcare systems across the country. But George, you and your teams have been using Cortex in collaboration with our provider partners for a while now. Would you mind walking us through that relationship? Why and how did it start? What's happening now? And why this approach and why now?
Sure. So, Humana has grown in some instances by especially acquiring provider-owned health plans, and so there are a few big examples of that. But the key important part of that to this discussion is that as a result of when those plans were provider-owned, they often had the same exact access to the same systems that were being used by the provider owner. And so there was real-time communication. You were seeing the UM folks on the plan side and the provider side were looking at the exact same data. Well, as time goes on, of course, once those acquisitions happen and people upgrade systems, et cetera, that went away. And what we were looking for is, how do we find a solution that can give us that exact same kind of integrated capability that we had when we had a provider-owned plan? And so in searching out for that solution, we came across a very large system that we were engaged with that was shifting to use Exelis and specifically the Cortex layer. And so what we did is we went and looked at that and tested it and found that it gave us the same real-time capabilities, so that there's no delay in getting the clinical information. Those faxes aren't used. The phone tag games that so many of us experience. I would just say this: if you haven't sat down in your provider office or the payer with the UM teams going back and forth and looked at them and sat with them and experienced the frustration they have when they need just one more piece of information on a clinical from one side to the other, and seeing how long it can take sometimes to get that connection, to get that data, it's phenomenal. So what the Cortex communication layer has done for us is allows us to get rid of all of that. There is no back and forth anymore. You as the plan and you as the provider are looking at the exact same information at the exact same time. There are even really good tools involved that allows each to say, hey, did you see I just updated the medical record with this information? And there's no need to send that information. The other party can just go and look at it. So that kind of effective communication is just so vitally important to all that we do. And if nothing else, the administrative burden and the headaches it takes out, not to mention the latency and the asymmetry of data that puts the member and the patient in the middle sometimes. So that gets taken care of when we're both looking at the same information at the same time. And so that's really how this evolved and how we started looking for the solution. We've implemented a number of different states now, a number of different hospital systems, and we are seeing immediate relief once this gets put in place on both sides, on the provider and payer side. The rollout has been amazingly simple, and it has given us both parties 100% access to the medical record with real-time information, and so that when we're talking about auths and approvals and what even what denials are, people can say it is this thing in the medical record that was the reason for the denial, or it's this reason why we think that the denial should be overturned. So that real-time communication has just been an enormous lift on everybody on both sides in how they engage in this whole process.
Great. Yeah, and I think, George, one of the things you've always asked, kind of responded to, you talked, as we talk about the relationships that you've been able to the engagements that you have with your hospital partners, is that improved collaboration, right, or that improved conversation, relationship, which is a byproduct of moving to technology, moving to analytics, moving to a more seamless way of communicating between payers and providers. So I know that certainly the administrative benefit is there, but I think that one of the ancillary benefits is the building of the relationship and improving of the relationships that you're seeing with your payers, your provider clients as well. So the one other we talked about the communication layer. We talked about the seamless communication between payers and providers through Cortex. Would you mind kind of elaborating just a little bit? One of the things that we bring to bear and to both the health systems or the hospital systems and to our payer customers is the application of artificial intelligence and machine learning that really helps to even take the relationship one step further. So the concept of precision helping to drive the length or level of care decisions, cutting out the administrative burden. Would you mind elaborating on the promise and what you see in terms of our ability and our collective ability to leverage more artificial intelligence to even further streamline the process?
Yeah, happy to, because that's ultimately where we want to get to. Ultimately, what we want to get to is where we're taking a very large amount, if not all, a very large amount of the back and forth over authorizations and approvals and leveraging artificial intelligence to get to an answer. I think all of us can conceptually get our minds around the fact that using artificial intelligence, you should be able to get to a spot that doesn't get into as much subjectivity between clinicians on what should or should not be, for example, an admission or not, should be an admission or an observation, or should just have been discharged. And so if we can, and we have some tests that we're seeing great results going on right now around this precision using AI, where if nothing else, think about it this way. What if we could take 90% of those back and forth discussions out, so that our clinicians on both sides are just having to discuss 5 to 10% of the authorization disputes or site of care disputes? That would be an enormous step forward for all of us. And I think that what we're seeing in the test so far is the potential is absolutely there. And so, this question about, is it interqual? Is it Medicare? Is it Milliman care guidelines? It doesn't matter. The fact is, the AI has the great potential to lead us to the correct answer, and if nothing else, significantly reduce the amount of time and energy both sides are spending discussing and arguing over the vast majority of the cases.
Thank you for that, George. And Doug, I know that in your world and your business, you have some practical examples of where that back and forth, that clunkiness, the manual nature of authorizations is challenging. Do you mind talking about some practical examples of the use of, or where you see artificial intelligence help streamlining the authorization process?
Yeah, I mean, y'all are talking about cars, and I'm still in the horse and buggy days, and I listen with some degree of jealousy, right? I mean, we basically are an organization that's dependent on outside referrals from specialists. All of the medications ostensibly that we administer to patients with some type of complex chronic condition typically have a prior authorization requirement attached to them. And so, a big part of the work that we do is actually go and get that authorization on behalf of that referring provider. So we have a team of people that takes that order, and then we work with the health plan to make sure that they've got the appropriate information to then make a determination and give us that authorization that we need to treat the patient and have confidence that we'll get reimbursed. But that process is unbelievably analog today, right? It is, a team of reps who literally hop on the phone and they talk to a team of people within that payer who, again, everybody is doing what they're supposed to be doing, right? And everybody's trying to make sure that this patient gets the right level of care. But because of the way that the process is structured, it takes an inordinately long time, and it's a bunch of back and forth, and it's going to get this additional piece of data. It's sitting on hold, waiting for somebody in a call center to free up. And I think that really is the opportunity for us, is how do you streamline these processes? Because at the end of the day, it's about the patient. And it's about making sure, especially for our patients, right? A big reason they go on these biologic medications is because they don't want those medications control their condition. And if they're not on it, they have a flare and they end up back in the hospital, which costs everybody money. And so, I think, like I said, I mean, we look at what Humana and Exelis are doing and how you're leveraging that real-time data feed and using the machine learning to make better decisions. And that's ultimately, I think, what everybody wants to do. But consider me jealous, that's for sure.
Well, we'll get there with you, Doug.
There we go.
There you go. So, and I think the other part of the conversation, we certainly, talk about the ability to leverage data to help make the right determinations. I think what really excites, and obviously I have a little bias here, but I think what really excites me about facilitating this sort of application within the healthcare industry is what we hear from our hospital customers and our payer customers or partners, is that by reducing this administrative aspect of managing the process, that allows clinicians to be clinicians, that allows people to get back to the bedside, that allows people to put the patient back in the forefront of healthcare. And so for me, that's really exciting and fulfilling to know that we are facilitating a process in which now we're talking about the patient care. To your point, Doug, to your point, George, we're helping reduce some of the administrative burden. We're helping put people back to engagement with the patients, which I think is so important to us and to all of us as we think about better caring for our patient populations. So before we move on to talking about some of George and Doug's insight into the industry trends, I want to talk a little bit about the work that Humana and one of our provider customers up in the Northeast did relative to managing through the COVID-19 pandemic. I think, one of the things that the pandemic has, among other things, shed light on is the pressing need for health information technology. One of the data-driven initiatives we were able to put in fairly quickly because of the footprint in hospitals was this real-time sharing of admission and discharge information for George, your members, in collaboration with the hospital system up in the Northeast. Would you mind talking a little bit about that effort and the impact and why it was important specifically during COVID-19?
Yeah, I think, one of the silver linings of a lot of the negative events that happen in the world is that you find new ways of doing things. I remember after Hurricane Katrina, I was living in New Orleans then and running a health plan. One of the positives that came out of that, for example, was that we went from a very large share of providers being on paper checks to everyone converting to EFT transactions. So In the same way, one of the great things about once you convert to a data layer, digital way of communicating, it allows for you to do so many other things. And so we, like many others, were very concerned when we saw what was happening with COVID, specifically in the New York area, and how that was growing. We wanted to have a better idea of what was going on with our members and our providers' patients. So because we had already been working towards installing Cortex in this communication layer, it allowed us to very quickly and rapidly move to a pilot where we're using the Cortex layer to see where members were being admitted and discharged, to get the ball rolling on how to get support to those members, how to get support to their families, so we could send care kits to the family, make sure the members being admitted to the hospital were getting the care that they needed, to make sure that there was no barriers in their way of getting whatever care was necessary. So just as we have found that COVID has accelerated, for example, the move to telehealth, COVID changes the way you start thinking about things, and you can start thinking more broadly and deeply about how you can change the way you interact and the way you can drive better data information when you have this communications layer in place. And so this is just one use case of many I think we will find that we can accelerate once we have this communication layer going on, where it's real time between providers and payers. And this just happened to be one example of how that communication layer can change the way you approach many issues. This happened to be a COVID problem. But I think that communication layer and the ability to communicate real time is going to open the door to all sorts of ways that we can collaborate better between payers and providers.
Thank you, George. I can't agree with you more, and I think, hats off to the Humana team and the hospital system up in the Northeast for realizing that that even in the midst of the COVID pandemic, that there was an opportunity to collaborate, to share, to better provide, to better apply solutions that put the patient back at the forefront. So then just another example of the great innovation that you and the Humana team are doing in collaboration with healthcare providers or hospital customers. So, again, what we're talking about in terms of the process, we're talking about in terms of the opportunity to do more real-time data sharing and access to data. And George, to your point, these are just the tip of the iceberg in terms of where the analytics, the real-time application, the access to data, the opportunity to create seamless communication between payers and providers. That's just one example of where organizations like Humana and our hospital customers are really changing the paradigm, leaning in to different ways to do that, moving away from per click to potential to value-based care. All those are really changing the way the industry works. But there's I want to get some thoughts from both George and Doug in terms of the trends that y'all see in addition to these areas of opportunities that we've been talking about today. According to some industry experts, data sharing / interoperability can cut healthcare costs by about $30 billion. Obviously, that's a pretty significant number. Some argue that it starts with the seamless flow of data information on patients, doctors, hospitals, and payers, and organizations are looking to third parties to help collect and synthesize that data. So George, first to you, would you mind kind of talking about what Humana is doing around those efforts and how and what you're seeing in terms of areas of opportunities and trends to really chip away at that $30 billion number?
Yeah, I think that I'll start by talking about one of the points that Doug brought up, which is the site of care shift that we see going on. There's no doubt in what we're seeing in our data that the site of care shifts have really started to ramp up and will continue. We're seeing a lot more care being provided in various settings that are at a lower acuity, and those those are leading to both cost savings and better health outcomes. So, for example, I mentioned the value-based bundle. So, for example, some of the things we're doing with various orthopedic practices, they're having to change the way that everything is delivered. The anesthesia protocols need to change. The rehabilitation protocols need to change. Everything needs to change around the way that those procedures are done when they're done in an outpatient setting. And data drives a lot of that. The shift in the reimbursement methodology drives a lot of that. And so that shift to different sites of care is going to have a huge change. There are a lot of services that are provided in higher acuity settings that can be provided in lower acuity settings to in the home if the right kind of technology and right kind of system with belts and suspenders are built around caring for the person in their home. Humana, it's not a secret, we've made a huge bet in the home space. We believe that patients would rather stay home. We think that most patients would rather have their care delivered in more convenient settings. And so we're making a very large bet there in where we're investing, what we're driving to. And, the data that we have thus far is showing that we can significantly reduce costs while improving outcomes. People talk about, well, but the home may not be as clean as another type of clinical setting. Well, that's true, but what's not clean about the person's home is something they've been living in, and they have developed certain immunities to whatever's in the home. But it's when you subject someone to a new environment that you create the opportunity for negative outcomes. And so, we've, for example, seen that something along the lines of 200,000+ days people are be able to stay home who are in a value-based arrangements. If you just think about that, members who are in value-based arrangements have 200,000 plus less days where they're in a facility. Their outcomes are also better. And so this whole paradigm shift of site of care and the value-based care is changing things pretty fundamentally. And I think that we're just now starting to experience where it can go as we get more aligned incentives and as technology and other support mechanisms support people being cared for more in home. Because if you think about a lot of people, especially in med beds in hospitals, there's a lot of that care that if you had the right technology and right care protocols wrapped around those patients, you could shift that side of care to the home. So that's one of the biggest trends we're seeing. Is that whole shift in site of care and how value-based is changing the way people are thinking about things.
Absolutely. Yes, I agree. I think one of the things, too, and as we see shifts in sites of care, the application of artificial intelligence and the data sharing, to not have to start at ground zero for understanding what's going on with a patient is going to be very critical to know, what care a patient received in a acute care setting is transferred, is known by that home health care agency or that different site of care, and not have to recreate that patient story is very critical as we see these shifts in site of care in the market. But Doug, any thoughts on that, or any other things that or trends that you're seeing that the healthcare industry focused on in terms of driving care or cost out of the system?
Yeah, I'd say two things we've done well, two things are opportunities. So the first, I think the good news is we have definitely made meaningful strides in digitizing the healthcare data that's out there, right? The HITECH Act in 2009, $27 billion of incentives, that helped to get us to a more digital format for data. I think that's foundational. I think the second thing is you need sort of data pipes, gateways, et cetera, whether that's a Change Healthcare, it's an Availity, it's an Optum. You need standards for that data, right? So FHIR and EDI and what have you. The good news is we've made progress there, and I think meaningful progress. I think the two opportunities for us, one, at the end of the day, I think transferability of the patient record is absolutely one of the most critical things we can all aspire to have. right? If you think about artificial intelligence as an example, it works off of longitudinal data. The more data it has, the more predictive it can be, and the better that it performs. Yet today, when a member changes a plan or a patient changes a provider, all too often, we're starting over. And so you're reducing the relative level of effectiveness of the machine, right? And so I think the more we can do to drive better transferability of the patient record, I think the further we'll go. The other thing, and I would say this is more for the audience's benefit, but as you all think about technology decisions that you're making, whether you are a payer, whether you are a provider, change that lens through which you're looking and think about, okay, is this a piece of technology or a platform that I'm using not only to make better internal decisions, but it's something that at some point in the future I can push out to other partners in the healthcare ecosystem to help them make better decisions. And I think the more that we look at things with that mindset, and the more collaborative we can be, I think the more successful we'll be, and I think that creates great opportunity and potential for the future.
Absolutely, Doug. I appreciate that, and your trend jump to the advice, right? I think that's good advice for the folks on the phone and part of the audience certainly is to look for opportunities that provide that transferability of patient data and help better understand what's happening with the clinical condition of the patient. Doug or George, any advice for the audience capitalizing or teeing off of or following up to Doug's comments?
I would just say that in line with what Doug's saying, I mean, you do have the FHIR APIs now that are out there. And if you're thinking about your holding of data, of course, with all the privacy issues appropriately cared for, it is a competitive advantage to just say that I think that we're not thinking more holistically about how to improve care for patients. We are, for example, we now integrate the Medicare Blue Button data in everything that we do, and so that the patient's prior medical records can come in, and vice versa. If they want to take them elsewhere outside of Humana, they can go. We become a qualified health entity so that we may get better exchange of data. To me, having the data and leveraging it appropriately and having it with all the right protections in place for privacy is something we should all aim for. But at the same time, we can't collaborate about how to improve the health outcomes for our members and for our providers' patients if we're not being collaborative with the data. So, it reminds the analogy I use all the time is the ATM. It used to be that banks thought that the ATM itself, the holding of the data, was what was important, what they would compete on. Over time, everyone realized that was just silly. That what's more important is not the ability to, use your ATM card at a particular bank. It's to use it at all banks, and it's how then the bank provides better customer service and how the payer. And so the analogy would be, it's not the data itself that should be the competitive advantage. It's how you're using that data to improve things for your customers. And so that collaboration that Doug brought about really is vital to the future healthcare system. And I think that a lot of the APIs have been developed about how we transfer patient data around is going to be critical. And if everyone's looking at just holding on to their data as their competitive advantage, that will pass. There's no doubt about that. That will pass just as it used to be that a particular bank had its own ATM system. All your customers had to go to your ATM to get that information. That's got to stop. Just to use a very real-world example, my son recently thought he had COVID. He got a test and he found out it was negative, and he needed that negative test to go back to school. Well, when we tried to get the medical record from the provider that provided it, they asked us to fax them a note on that and get the exchange that we could do it that way, and then they'd mail it to us. And I thought, you're kidding me. My son's going to be out of school for days just because of this antiquated way of doing things. That's just a real-world example of what's got to stop. The data and who holds it and how we hold it can't be our competitive advantage. The competitive advantage that all of us should be aiming for is how do we then use that to improve things for everyone. So anyway, I think that collaboration that Doug brought up is just vitally important.
Absolutely, absolutely. So, and thank you both, Doug and George, for those comments. The good news is, I think, although you focus on a very narrow set of opportunities within healthcare through in the utilization review space, we certainly, through our partnerships, healthcare, our payer and hospital partnerships, certainly helping the market kind of lean in and to better think about collaborating, using data, using artificial intelligence in a different way that's never been done before, and all for the right reasons, for reducing the cost of healthcare, for better seamless collaboration between payers and providers, and most importantly, to make healthcare more, to continue to improve the ways in which healthcare is focused on the patient as opposed to administrative aspects of managing care. So appreciate Doug, George, your participation today. Exciting stuff for us to think about, exciting advice for the audience to think about. So again, thank you for the dialogue today. I think at this point, I think we're going to open up the floor to questions. I think, Brian, you have some questions teed up for the panel.
Absolutely. Thank you so much, Joan and George and Doug, for that very engaging, informative discussion. And as Joan mentioned, we will now begin today's question and answer session. So as a reminder, please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we can. And we've really had a lot of great questions come in already. It's a very engaged group. So to start, though, I think there's been a lot around there's been some themes that emerge in these questions. And Joan, I'd like to start off by throwing you one that's sort of a composite of a few questions. I'm wondering if you can elaborate more on how the provider interfaces with Cortex. How does Cortex get the data? How do hospital staff use Cortex? And how do they share that data with payers?
Sure. So forgive me if I get a bit techie on that. So the plumbing in which Cortex receives the data, it's like I said in the previous remarks, it's a real-time interface between Exelis, Cortex, and the hospital's EMR. So just to give you a little bit more detail, we receive labs, vitals, medications, orders, the narrative text of a document. All that comes through pretty consistently through HL7 feeds into our platform. That then gets normalized, then it gets run through our analytics engine. So we talk about, and Cameron, if you wouldn't mind, there's a slide, I can actually get to it, but all that data then gets normalized and promoted through Cortex, which creates that concise clinical picture of the patient. And then Cortex becomes that common framework. It's a SaaS application, becomes that common framework through which both payers and providers collaborate. So if Joan Butters is a patient within the hospital, her information gets promoted through Cortex. That hospital UR staff is looking at Joan Butters, and then the payer, same thing on the payer side. That payer nurse or staff member is looking at that same information through Cortex. And that's, I think, the beauty of the platform, is to George's point, is there's no second guessing, there's no question. Everybody's using that same information to make decisions about that level of care. So it's really, I think it's real-time connectivity into the hospital's EMR, the promotion of the output of that information, and importantly, the analytics, and then both parties looking at that information through the Cortex application.
Joan, thank you so much for walking us through that again, and we'll move right into the next question. Joan, you can weigh in here. George, maybe too. So the question is, it regards the AI function on the platform. So while AI may and probably does assist in status determinations, it's not the ultimate decision for a status determination of the plan, and it's still subjective, regardless of MCG, interqual, or what AI suggests. To account for this, is there an agreement between hospital payer using the platform to agree that the status determination is what the AI suggests or generates? Does that make sense?
It does. Thanks, Brian. And George, I'll take that one first, and then if you have any comments or supporting points to make. I appreciate it. But so great point from that question. Certainly AI can't replace a clinician, right? At the end of the day, it is directional in nature, right? It's using the information at the time in which it gets and be able to, with a very high degree of accuracy though, to be able to identify what that level of care is. But ultimately it's the final decision of the clinician is the final decision maker on what that level of care needs to be. However, they're at the very highest levels of predictability with over a 99% accuracy. Those are the ones that George talked about in terms of imagine a world where we can get to 90% of those decisions are made through AI, and it leaves only the 10% to be discussed between the payers and the providers. And I think the other point, too, is that through the application of artificial intelligence, it's a learning, it learns upon itself, right? So as we continue to accumulate more data, accumulate more information about patient conditions, that AI gets smarter. And so ultimately, envision a world where minimal touch by a clinician, minimal need for a clinician to make those final determinations so that it becomes as seamless and as minimal touch as possible through the process. The second part of that question is yes. There's a dialogue between the payer and the hospital relative to what that level of accuracy needs to be for it to make sense for both the payer and the provider. And that is an agreement that both payer and provider come to in part of the dialogue between both organizations. George, do you want to comment at all about that? Specifically about the payer provider agreement? Yeah. Mm-hmm.
Yeah, so it may be that, and I'm just going to use some numbers just for purposes of illustration. So let's say that the AI tool would say a score of a patient score, because you heard Joan talking about how the AI scores every patient according to appropriate level of care. Let's say that the score where a patient should be admitted is 125, just making up a number. So what we would do is we would agree with the provider that, look, neither one of us wants to use an absolute score because it's probably a gray area where both of us would want to have a discussion. So just making something up, we set it at anything below 120. There's no question that if that's what it comes out, that it may not need to be an admission. If it's over 130, it needs to be admission. And what we then do is we agree between the payer and the provider, between the two of us. We say, great, so we'll review everything at 121 to 129. And so we agree to what that interval is, and that drives, and we can look at the data to tell us that means that's 5% of all the admission authorizations. And so you come to that agreement, you say that we're going to agree that that's what our team will focus on. So 95% of this, we let the AI make a determination, which, as Joan says, it continues to learn. So anyway, that's how we think about it and how we're thinking about this going forward and the way we've been testing the system.
Thank you both for weighing in there. And George, I think we can stay with you for this next question. So attendee asked, what's the best approach for engaging with the payer for a better value-based approach? Providers and hospitals are not able to obtain data to see how they are necessarily performing compared to local regional peers, and what kinds of changes are needed. So what is that best approach for engaging with payers for a better value-based approach?
So I'm just going to read in that the data may not be very good. I mean, we have spent a ton of time developing a value-based platform that we call Compass that provides enormous amounts of data and information. And one of the things that we do a little bit differently sometimes than some of our peers is that we actually have a provider engagement manager assigned to every single value-based provider, because we have so much data and information. Using that example I did earlier about the provider that had 2 new doctors that weren't seeing their patients. I mean, we can drill down at that level, and it's that person's job, it's that provider engagement manager's job to make sure that we're focused on what's the next best use of the time and attention between us and the provider. It may be things around gaps in care. It may be Medicare risk adjustment. It may be patients that there's a too large segment of the patient population that hasn't been engaged and hasn't been seen. And we can benchmark that against both other providers in the marketplace as well as national. So I'm not sure exactly where the question is coming from, but through our Compass reports, we can engage and provide data at almost any level to the providers in the value-based arrangement with us.
Thank you, George. And we are running out of time here, but I do want to get Doug involved, get your input on this next question here. So we'll at least take this one more question, and George, maybe you can weigh in as well. So the question is, do you think that the recent CMS ONC regulations around the 21st Century Cures Act, introduction of standard APIs for data access and sharing, will improve the current situation?
I think it certainly has the potential to. But, I would say, like any piece of government legislation that I've seen passed, there are always pluses and minuses, and how it's implemented is really what matters. I would say there's still enough moving parts that, it's hard to tell if it's going to have the same type of impact that maybe we saw out of the HITECH Act in 2009.
Thank you, Doug. Anything to add there, George?
No, I think what Joe says is exactly right.
Cool, great. Let's take one more and then we'll sign off. So, what are the skills that we should hire for to get a provider or a payer organization aligned on improving data sharing in a more efficient way? So often we do not have the internal skills to approach this. Doug, I'd love to hear from you again on this one, and George perhaps as well.
Yeah, I think that willingness to collaborate, that willingness to be in unfamiliar situations, one of the things we talked about at the end of the day is assume positive intent, right? At the end of the day, we're all in an incredibly impactful industry, right? We take care of people. And I think not losing sight of that's really important. That at the end of the day, the patient, the member is sort of our collective North Star. And our job is to get them the most appropriate care when they need it. And just somebody who's got that feeling of empathy and kindness, I think really is important, because if you can be mission-driven and purpose-driven, that's going to let you rise above a lot of the noise that kind of exists in the system today.
Yeah, I would just add that one of the great things about the move towards value and away from volume is that it aligns incentives and creates an environment where it's a win-win-win for the provider, the payer, and the patient, where we're all aligned around the same thing, which is improving the health outcomes for the member. Because we know without a doubt that when you improve the health outcomes for the member, it reduces costs and allows us to provide other valuable services, and the provider provide other valuable services to the member that maybe we couldn't under the old volume-based world. We're doing things and covering things today that I never thought I'd see. We're covering food for members. We have provided over-the-counter benefits that you never would have seen without the alignment around value. So the more value we're driving in the system, the better it is for our members, the better it is for the health outcomes, and the better for the system as a whole.
Thank you both. Some great closing thoughts there. Great closing comments. Joan, anything to add before we sign off?
No, other than appreciate it. The dialogue's been great. Lots of topics covered. I think that hopefully this was a benefit to the audience, and look forward to continuing to have these types of strategic and more forward-thinking conversations. So appreciate the time today, and Brian, thank you so much for facilitating the webinar.
Absolutely. It was a pleasure. Thank you so much, Joan, George, and Doug, for that excellent conversation. And I also want to thank Exelis for sponsoring today's webinar. Enjoy the rest of your day, everyone, and we look forward to having you join us for future webinars.
Thanks.